we are having now a focus from the ICMR institutes, a slight shift of focus from epidemiology and infectious diseases to non-communicable diseases, with a few newer institutes on non-communicable diseases, more and other for implementation research in non-communicable diseases as well. And we want to look at what work has been done and is being done in terms of diabetes. I think the two major projects that are, one is the Young Diabetes Registry, which is recruited more than 21,000 patients of young diabetes, and Dr. Nikhil will be presenting the data of that. And then the INDIAB study, which is across 30 states with more than 113,000 samples, which is looking at it. And now we are having the NFHS 6, which is starting very soon. And the NFHS 6 has got HbA1c as one of the parameters to be measured. And if anything else needs to be added in NHFS 6, this is the time that we should debate on this and decide what can be added for investigation in NFHS 6. There were suggestions about vitamin D, there were suggestions about other tests to be done, but I think HbA1c is one which has made the cut, and it is definitely being done in an FHS 6. So I would welcome you all and congratulate the two people, Dr. Mohan and Dr. Nikhil, and all their collaborators with different institutes, different states, how they have managed to generate a wealth of data for the country, which now is seeing the light of the day. And also much of the data can now be, the samples can be investigated and more research generated out of that. So I wish all the best to all of you, and I won't stand in between the speakers. And today is a very important day. I mean, if I have a very basic question, which if someone asks you at the age of 50, or if God asks you, what disease do you want, diabetes or hypertension? What disease would you choose? I would probably choose diabetes, because hypertension and hemorrhage and brain hemorrhage and strokes are probably more worrisome than the other complications of well-controlled diabetes. So I think this is also an open question, and I would leave it to you whether you would choose diabetes or hypertension at the age of 50 if you were asked by God, what disease do you want? I would definitely choose diabetes compared to hypertension. Although we have excellent drugs without side effects for hypertension, many excellent drugs, but still somehow that fear of a stroke or even of a brain hemorrhage is more worrisome than the although renal complications and of diabetes and other eye complications, retina complications, and microvascular disease in the heart, and all are definitely there with diabetes. But I just leave that question and just toss it in the air for you people to decide. So all the best. Thanks.
Thank you, sir. May I now request Dr. Nikhil Tandon to give his presentation?
Thank you, Professor Balram Bhargav. I think you've left us with a difficult question to answer. None of the above would have been a very nice alternative to have been put on the table. But anyway, we will think more about this. Can I share my screen, or do I need permission, Dr. Tanveer?
Yes, you can share.
You can share, sir.
It's already there.
So I will be speaking this morning in two halves. One is just to remind, can provide a historical perspective. Part of my job was already done by the Director General, and I think, but it's still important because, historically you can always gain inspiration from a lot of work done, and then I will sort of narrate work done for the ICMR Young Diabetes Registry. So life before the discovery of insulin was really, really terrible. It was invariably a fatal disease. The most effective treatment was to put patients on very strict diets. If you look at the starvation diet in the middle panel, and they very kindly put the calories there, this adds up to 120 calories right? Really. It's written 150, but it's actually about 120 calories, maybe the little milk and tea or coffee is adding up. And the result of that 120, 150 calories diet is visible to you in the right panel. This is a mother with a diabetic child. And I don't think there's anything more pathetic that you can see. And you can see your own child shrinking, shriveling, and disappearing in front of your eyes. And that is really a terrible, terrible situation to be in. So as mentioned, Sir Frederick Banting, this is from London, but London, Ontario in Canada. He conceived the idea, and I'll give you a little bit more about it in the next slide, but that led to the discovery of the use of insulin for treatment of diabetes. And this is from his lab notebook on the right-hand side, which says, ligate the pancreatic duct of the dog, keep the dogs alive till the acini, which are obviously the glands which produce the exocrine secretion, degenerate, leaving only the islets. Then try to isolate the product, whatever is being produced by the acini, inject them into and see if they can relieve glucosuria. So that in one sort of paragraph or one sentence really was a summary of the plan of Banting Best under the tutelage of MacLeod. This really gives us a sort of historical narrative of the development. But before I go to this particular slide, I think it's important to say that in the last 30 years of the 19th century, a lot of work had been done, starting with Paul Langerhans, who identified that these are entities within the pancreas, then work by Oskar Minkowski and Joseph van Mering, who essentially showed that dogs who had a pancreas removed ended up with fatal diabetes. And then work done by Sharpie, Schaefer, Bayliss, and Sterling, who demonstrated and proved that that these are the islets which produce a substance. The concept of a hormone produced, it was released by Bayliss and Sterling when they were working on secretin, and then eventually the word insulin came into being. So this was the backdrop of work when Banting opened his medical practice in London, Ontario. It was his idea. He went to meet MacLeod, who was a professor of physiology with immense interest in diabetes at that point in time. And then he was joined by a bachelor student in biochemistry and physiology, Best. They began their experiments in May of 1921. And then by July, they were looking at the activity of crude extracts in a pancreatized dog. The same had then happened by early 1922, and the results were published in 1922 March. And of course, a patent was applied, and then the two major companies, well, there are three major companies that produce insulin, but Eli Lilly was the first one to get it active, and then August Krog, who was an academic, visited Canada, took permission to produce this in Scandinavia and established the Nordisk laboratories, which then eventually became Novo Nordisk. But even more remarkable is from the time Banting presented his idea to MacLeod on November 8th, 1920, it was under 3 years when he was awarded the Nobel Prize. 3 years from start to finish cannot be more inspirational. But if you see this photograph, you will see why this was merited a Nobel Prize. The same patient whom I had shown earlier in December 1922, weighing 7 kilograms, had gained another 7 kilograms within 2 months of initiating insulin, looking much more human and healthy compared to that photograph. And I think that is the contribution of insulin. If we just leave this photograph, that is enough. The rest becomes redundant. The other thing which is important, we don't seem to realize this because we've all been born and worked in the insulin era, is the discovery of insulin significantly improved life expectancy. In 1913, before the discovery of insulin, if you got diabetes at the age of 10 years, you were likely to live 15 months. So you lived till the age of 11 years and 3 months when the average life expectancy was 54. In 1945, you got diabetes at the age of 10 years, you lived another 35 years. So you lived till the age of 45 when your non-diabetic peers lived till the age of 66. So a 20-year gap. This was a 50-year gap. And in 2015, if you developed diabetes at the age of 10 years, you lived till about 60 years of age at average, when the average life expectancy is 80 years. So that's a 20-year gap. Now, compared to what was in 1913, this is huge. Surviving till the age of 11 years to the age of 60 years, that's nearly a 50-year increase in life expectancy. But listen, people with type 1 diabetes are still living 10 to 20 years less than their peers, and that is our battle from now onwards. So there were multiple innovations since the discovery of insulin. I will not take you through, but after the crystallization of insulin in 1926 and Dorothy Hodgkin's work, who showed the first X-ray photograph of the insulin crystalline, most of the work till 1960, for the first 40 years, was related to prolonging the action of insulin by adding protamine, by adding zinc, by adding different components, and eventually the NPH insulin, which we even use today, the neutral protamine hagedon, came into operation. In the 70s onwards, the first thing which was done was, since till then, most of the insulin being used was either bovine or porcine, was to develop an enzymatic method to convert porcine insulin to human insulin, which is only different by one amino acid. And then, of course, Genentech came up with the first production of a recombinant human insulin, which was then commercialized by Eli Lilly. And then in the 90s, or the mid-90s onwards, the next huge thing happened, which was to create analogs, either short-acting or long-acting, which tried to mimic the secretion, physiological secretion of insulin in the body. And so three major journeys: 1936, discovery of protamine; the late 70s, early 80s, introduction of recombinant human insulin; and mid-90s, the discovery of analogs so that they could be injected immediately prior to the meal. It gave them an advantage, and they work more like human insulin in a physiological circumstance. And this slide essentially summarizes everything. And of course, I will not take you through this slide except to show you one fact, that the early insulin concentrations were as poor as 5 units of insulin per ml. So if somebody needed 20 units of insulin, they needed to take 4 ml of insulin, which is massive. The second thing you realize is that most of what was happening till here was using animal insulins. And the other important step in animal insulins and human insulin was to purify them chromatographically so that we develop what is called monocomponent insulin, which had less than 10 parts per million of proinsulin, thereby reducing the allergenicity, reducing the likelihood of allergic reactions of lipoatrophy and lipohypertrophy. And then, of course, as I mentioned, recombinant insulin and the various analogs came into picture. What about India? India has done very well for insulins. You know, the affordable insulins are available in India, both by the efforts of manufacturers and also by the intervention of the government of India, by making it an essential commodity, have put a price cap. Most of the companies worked on the principle of fill and finish. They would get material from abroad, fill it in vials, and then present it. But 2 companies have since started making recombinant insulin, Wockhardt and Biocon. Biocon actually makes the first yeast-based recombinant human insulin, and they've now gone ahead to also make a basal analog of insulin. So we're not doing badly compared to so many countries in the world where there is no local production of insulin, and it is way beyond the reach of a lot of their population. As I finish this part, I'm going to quickly run through 3 slides which show you how insulin was delivered. So these were the prototypes of different syringes, but the story I want you to read is the one on the right, which says, given the low concentration of insulin in the early years, a patient had to take 5 ml at a time. Her syringe held only 2 cc, so the needle had to be left in place. While the glass syringe was unscrewed and refilled twice, the process took 20 minutes, and her hip used to swell and the leg used to go numb. But she was willing to do that because it allowed her to eat normal, real food. But this is where we are today. Very sleek, very nice, disposable syringes, which are available, which are single unit syringes, and life has become simpler. But just as they say that the pen is mightier than the sword, the pen perhaps is even mightier than the syringe. And this was the first pen which came out in 1985. And now we have a plethora of pens which have aided delivery of insulin, making it easier for people who are visually handicapped, who have other disabilities, and they have really made a little difference to that. And finally, the evolution of the pumps. Again, I want to just show you one photograph here. This was the first wearable pump. This is bigger than an average backpack we use today to take food, to take our stuff. From this first massive size pump to the pumps today, which are not only small, which are computerized, which work on very neat algorithms, it's a very, very incredible journey which has happened to us. So let me stop here again, sharing with you once again a photograph of a child before and after therapy with insulin. And I personally feel that it was not a privilege for Banting and MacLeod to get the Nobel Prize. It was a privilege of the Nobel Foundation that they could give a prize to these people, because anybody who made such a dramatic impact on human life deserved not only the Nobel Prize, but much more. Let me shift now to the registry of people of diabetes in India with a young age of onset. I think recognizing the criticality of youth onset diabetes, this decision was taken in the early part of the 21st century after a workshop conducted by the ICMR in collaboration with WHO. A decision was taken, and this registry was launched in 2006. And must put on record, the yeoman service provided by the NCD division at that point, Dr. Tanveer Kaur, was primarily instrumental as a nodal officer in getting this off the ground. This is the publication which gives us the whole background, but I will take you through some of the sort of relevant points in this particular registry. Number one, and I think the ICMR has reason to be proud of, this is the largest national registry for youth onset diabetes in the world. This is absolutely spectacular in terms of what it has done. It has recruited 21,500 plus individuals with youth onset diabetes. It operates through a hub and spoke model, 11 regional collaborating centers in 9 cities, but 205 reporting centers. That is an incredible number of sites where information is being accrued. Primary data collection happens in 205 reporting centers and counting as I speak. We have a database of 10 variants of diabetes, predominantly type 1 and type 2, but all the others also. And there are follow-up data available for the past 20 years. Again, there are some good data, there are some great data, but there are still lovely data. And this is a map of India which shows the spread. Srinagar, Chandigarh, Delhi, Mumbai, Manipal, Chennai, Cuttack, Imphal, and Dibrugarh. Fairly well scattered. And the principle of this really is the collaborating centers, which I've shown you. These are 11 collaborating centers which network with reporting centers. For example, if you take a collaborating center in Delhi, Delhi has 2 collaborating centers. This is the AIIMS collaborating center, which then looks at the reporting centers which are scattered in the south and the western and southwestern part of Delhi and the Delhi NCR. This is a similar pattern which is available for all other collaborating centers. What is then done is that the primary data collection, remember this study till now is a bloodless study. So we look at questionnaires, we look at blood test reports which have been done for the patient as part of a service, but we do not take blood samples. So the reporting centers are the primary areas of data collection. Data from these reporting centers goes to a collaborating center where the data is compiled, cleaned, and subjected to quality control checks. Once that is done, the collaborating center sends the data to the National Technical Coordinating Unit, whose responsibility is to manage and analyze the data. And that is then sent to the National Coordinating Center for overall management and coordination. So let's give you an example. AIIMS will serve as a reporting center. Dr. Mohan's clinic will serve as a reporting center, but they are also collaborating centers. So they will send their data to their own collaborating center in addition to other reporting centers. The reporting center will then collect this data and send it to the National Technical Coordinating Unit, which for this particular study is housed at AIIMS. We then manage the data, do the analysis, and send it to the National Coordinating Center, which is at the ICMR. The criteria for recruitment of this particular study was fairly simple. Though it started in 2006, we allowed recruitment of patients ambispectively. So even retrospective acquisition from the 1st of January 2000, but 2 important criteria had to be met. At the time of diagnosis of the disease, the patient had to be 25 years or less in age. That's why it's called a youth onset diabetes registry. And the second thing was that patients must be coming from an assigned geographical area. Now, we know that this study is largely metropolitan urban India, and there are a lot of patients who come to Delhi or Chennai or Mumbai from far off cities in the hope of getting good treatment. But we needed to define a geographical area so that we could have a denominator, which would help us in getting a percentage prevalence if we so needed, but more importantly, also to derive an incidence of disease. So an assigned geography. So in Delhi would be Delhi NCR. For Chennai would be the municipal corporation limits of Chennai. For Mumbai, it'll be the limits of the Mumbai Municipal Corporation. These are the timelines and data sources. As you can see, the first phase, over 10 years, retrospectively, we took data from medical records. Prospectively, everybody has a baseline pro forma, and then annually a follow-up pro forma. 5,500 people in the first 10 years, 3 times that many in the next 10 years. We've done 15,000 in phase 2, which we censored in 2019, 21,000 patients. And that's a really, really big number. I'm emphasizing that, but that's important for us to see. The software for the YDR was, for the first phase, was made at AIIMS, and for the second phase was developed by another ICMR institution, the NCDIR. But for the sake of operational ease, because we are the technical coordinating unit, it is managed at the AIIMS computer facility. Just a few screenshots. This is what the login panel looks like. This is how the next page looks like if we log in from the AIIMS Collaborating Center. If you click on data capture, you will then be able to add a new proforma, search proforma, export to Excel. And then you can actually, at the level of the National Technical Coordinating Unit, get information about all baseline and follow-up of all these. And you can see the numbers right at the very bottom. Very nicely made. And currently, this is how we manage the data flow. So regional collaborating centers manage a manual backup at their own sites, send the information to the National Technical Coordinating Unit, which also maintains a manual backup. And then they are hosted on 2 servers at AIIMS, a production server, which is the one which is actively in use, and a backup server, so that we are hopefully protected from any data mishaps. Let me share with you some basic highlights from the YDR. As you can see, the 2 prominent sources are type 1 and type 2 diabetes. About 2/3 of the patients are type 1, about a quarter of patients are type 2. But we have, remember, it's 21,000 people. So 4% of 21,000 is still a very large number. So you have about 4% with GDM, 3% with MODY, people with chronic pancreatitis, people with secondary diabetes. And these are data which are waiting for further in-depth analysis. But the point I want to make, which is very critical from a service viewpoint, is that if you then bifurcated this registry into those who were diagnosed before the age of 20 years, this study goes till a diagnosis before 25 years. If you limit it to those less than 20 years, 85% of those are type 1 diabetes. But if you then take those who are diagnosed between the ages of 20 and 25 years, you see what's happening. Nearly 50% of them are type 2 diabetes. And Dr. Balram Bhargava is one of this is my contemporary in age, and there are several others who will remember that when we were undergraduates, if we diagnosed somebody who was 20 years of age or 21 years of age as type 2 diabetes, we would have been invited for another exam. That would have been the end of that exam. But today, if you're diagnosed between 20 and 25 years of age, 50% chance that you will have type 2 diabetes. And that's a matter of huge, huge concern. And I think I wanted to highlight that. The second thing which has come up, and this is the beauty of the registry with multiple sites, is the heterogeneity. If you look at phase 1 data, you'll find that there is a bulk which is happening, which is type 1. But Chennai and Dibrugarh, about 40% of patients are type 2. And when we went to phase 2, another site, this is the RIM site in Imphal, again had about 40% of the patients had type 2. So again, there's regional heterogeneity. Could be partly because of the sort of reporting centers, could be partly because of cultural and other factors, but again, very, very critical early observations which need to be worked further. So what were the key findings? The mean age of diagnosis for youth onset diabetes was, in type 1 was about 13 years, for type 2 was 21. 50% of patients with type 1 diabetes were actually reaching our reporting centers within 6 months of symptom onset. Therefore, it meant that they were reaching specialist centers early enough for early interventions. The most common mode of presentation for type 1 was a combination of osmotic symptoms and weight loss. But worryingly, 1/3 of youth onset diabetes were identified only incidentally. That means they could have gone on even longer, contributing to a significant complication burden. And that's what I wanted to point out, that about 1 in 7 patients, 10% of diabetes type 1 and 1/4 of type 2 diabetes in the young had one chronic complication at the time of registration with our reporting centers. That means they had already had diabetes for some time and had not been managed too well. Again, another 1 in 7 had one comorbid condition, such as hypothyroidism, dyslipidemia, hypertension, tuberculosis, and sepsis. And nearly 60% had at least one episode of hospitalization due to an acute medical condition related to diabetes. This is a disease which should be having ambulatory care. 60% of patients requiring one hospital admission means the community care was not great. So the demographic and clinical profile was published in Pediatric Diabetes in 2019. Again, one of the top journals for youth onset diabetes. And I'm going to sort of come to the very last bit of my talk by sharing another initiative, again supported through the ICMR. This is work which is not PAN registry, but is work which has been done between the AIMS and MDRF and collaborators in the US. So this is again supported by the ICMR. And this was in collaboration with SEARCH, which is one of the most well planned and executed youth onset diabetes registry anywhere in the world. Interestingly, it started around the same time as the ICMR registry. However, this had a cohort component and had the ability to do a lot of blood work. So that makes it different.
What are the new, when is the new place getting ready? New place? Dispensary, our old building. Getting ready, when getting ready, our dispensary next to ashram.
I think I have somebody else speaking. May
I think Ekedas can kindly mute.
So I just wanted to highlight a couple of points with this registry. Number one, knowing the importance of data privacy and data confidentiality, we did a very interesting form of data harmonization. No patient data was shared with the US collaborators, and we did not seek access to theirs. This was an harmonization method, which is called the Observational Medical Outcome Partnership. We essentially, what we did was looked at all the variables which SEARCH used, looked at all the variables which YDR used, looked at the common variables and mapped them so that then we could just look at common variables and in an anonymized fashion provide summary data of these anonymous variables. Again, one of the most innovative new strategies for data harmonization. This has resulted in 4 publications, and I think this is actually incredible for a small study supported by a relatively smaller amount of money, 4 very high impact publications in pediatric diabetes. One, which looked at the clinical profile and compared it between a US registry and an Indian registry, again pointed out 2 unfortunate findings. Number one, that our average glucose control was clearly poorer than that in US. So it gives us sort of flags this for us that we must work harder. Remember, the participating sites are good sites, but I must point one thing out, that this was baseline data at the time the patient registered in those specialist sites and does not reflect the quality of care by the specialist sites. The second thing, which was rather interesting, was that traditionally we think of type 2 diabetes as a disease of the obese, but in India, 40% of our youth onset type 2 diabetes in the registry were either underweight or had normal BMI. Very, very important observation. And that means relying on a screening based on BMI alone will not be adequate. The second thing was a comparison of diabetic ketoacidosis and acute hyperglycemia. Again, very interesting. And you can see how the curves separate between YDR and SEARCH. And you can see actually our ketoacidosis data are not worse than the US. The third thing, however, was a comparison of glycemic response to the treatment regimens which are being done, this again shows, unfortunately, that the control of glucose in Indian settings needs a little bit more effort to come up to international standards. And fourthly, this was a very, very difficult piece of work, but we used a technique called capture recapture to identify the incidence of diabetes and compare it with the US. And again, very interesting early data. This is one of the really most robust pieces of incident diabetes ever reported from a less resource setting. So I'm going to wind up here by saying we're now at the threshold of the third phase of the YDR. And this is where, by taking cues from search, we have requested the ICMR to support a cohort component, which will be done in selected centers while the registry continues unchanged. So this will be participants of IDR in 4 collaborating centers, the 2 centers in Delhi, the Madras Diabetes Research Foundation, and 1 center in Northeast. They will then contribute to a cohort study with baseline blood samples and follow-up so that we can get much more detailed information, and also contribute to the development of a biorepository. As you all know, the ICMR has decided to take on a major initiative of establishing a centralized biobank, and we are hoping that we'll be one of the first studies to contribute to that biobank. Let me just wind up with the potential future directions. Of course, with the cohort and biorepository, we think we're coming to a very exciting stage. But more importantly, as Professor Bhargav said, I think we've now got a platform which, in collaboration with the ICMR Institute for Translational Research and NCDs established at Jodhpur, we should be able to think through important research questions and design implementation and translational research projects to make an impact. We have now enough baseline data, and we will also like to extend our collaboration with other international registries so that we can share this information and come up and become important global players in the game. Thank you so much for allowing me this opportunity to present this information. And once again, I like to put on record my gratitude to the entire team at ICMR, especially the Director General, who's been very supportive, and the NCD division led by Dr. Dhaliwal and by Dr. Tanveer Kaur, who played a very, very critical role in giving us every possible support to ensure that this study has reached where it has. Thank you.
We are not able to hear. Should I go ahead?
Mohan, am I audible? Mohan, am I audible?
Yes, Ashok, you are audible.
I think Nikhil has given a superb overview, and it says all about all that has happened upper YDR. I just wanted to say one thing, that we also must, that has been one of the visions of our DG, Professor Balram Bhargav, that we should also show the way to the SAARC countries, Nikhil and Mohan, because you showed last 2 lines, you said, of course, with Europe, of course, with the Australia, other things. But Nikhil, always it has been the idea of our DG that we should take leadership for the SAARC countries. So I think you understand what is my feeling, that I want to say that we should take up that with Dr. Dhaliwal's support as early as possible, and form a network of we have a SAARC society, Mohan, you know that. We do a SAARC meeting every alternate year, but we can do through that or beyond that, take it forward. And super presentation, Nikhil.
Thank you, sir. I totally agree with you. And again, we look towards the ICMR leadership and their network with other medical research societies within the region to show us the way. And we promise them that we will do our utmost to provide the necessary technical support for that. Thank you, sir.
Thank you, Nikhil. Super.
Thank you, Dr. Das and Dr. Tandon for that exhaustive talk. May I now request Dr. Mohan to please give his talk on in-depth study.
Thank you, Dr. Dhaliwal. I'll also try to share my screen. I hope you can see my screen.
Yes, Mohan, visible.
Yeah,
Visible,
thank you.
Mohan, visible.
Yeah, thank you. Respected DG, Dr. Balram Bhargav, Dr. Dhaliwal, Dr. Tanvir Kaur. After that superb presentation by Dr. Nikhil Tandon, and I wonder whether you all noticed that the DG mentioned July 27th, and today is actually July 27th. So actually, to the date, we are at the 100th anniversary of insulin discovery, and we could not have chosen a more historic moment to do that. And seeing those pictures of those children in Toronto, who were literally dying of diabetes, recovering after taking their insulin, was a very moving sight. Just wanted to mention, although it's not part of my presentation, that I've managed to dig up the history of diabetes in India and pre-independent India. It was very difficult to get this literature, sir, because you mentioned, Dr. Aliwal, you mentioned that ICMR is 110 years old, but the problem was that it's very difficult to get the old literature, and most of it is published in the Indian Medical Gazette, which is also more than 100 years old. And it's remarkable how much of wealth of information is there in that. So I made a summary of all that, and that's being published in the Journal of the Association of Physicians of India. I think in the next 3 or 4 days, it will be published. And that will be a historic article. And I want to continue this work because so much of pearls of wisdom, and I would say diamonds and gold actually came out when we started digging. But unfortunately, it's all forgotten because in the British period, and everything was forgotten. And no less dramatic are the changes which occurred in India. In fact, this morning, in the Times of India, it's come in the Tamil Nadu editions. The first child who received insulin in India was a Kumudini, a 12-year-old girl who was treated at the St. Carmichael's Hospital in Kolkata in the 1920s itself. And Dr. J.P. Bose, who's been completely forgotten, who really is the hero of diabetes. If you look at some of the papers he has published 100 years ago, it is remarkable. My hair just stands up when I think of what Dr. J.P. Bose was able to do. So we had actually put his photograph, and the JAPI article has all of it. But I'm just digressing because I was so excited by seeing Nikhil's presentation and the historic, how historic today is, that I couldn't help sharing this with you. But I'll be happy to pass that on to ICMR. And I think this should be recorded. The history of diabetes in India should also be recorded, because remarkable work has been done by Dr. Mitra, the other Dr. Bose, Chunilal Bose, Dr. J.P. Bose's father, and then Dr. Bose. And it's remarkable that even in 1860s, there were people talking about diabetes in India. And of course, the two hotspots were Madras and Calcutta. Of course, Madras presidency included the whole of South India, and then Calcutta. And not surprising, because the British were in these two cities. But I'm not going to go into that, but it's remarkable how much of work has been done and published from India at those times. Now, let me move on to the second project, which is of great importance. And this is a kind of a study, which is a once-in-a-lifetime study, I would say. The Indian Council of Medical Research India Diabetes Study, or the ICMR InDiab study. And this is funded by the ICMR, New Delhi, and the Department of Health Research. I'd like to once again formally thank the DG, Dr. Balram Bhargav, and Dr. Dhaliwal and Dr. Tanvir Kaur. I'd also like to thank all the previous DGs. I think the study has already seen 3 or 4 DGs, because it has already finished 11 years of its study. And so the fact that the study is still going on and we are able to complete it itself is a great tribute to all the, not only to ICMR and the support given by the NCD division and the diabetes division, but also to all the PIs. And a big salute to all of them, since there are 30 states which you have completed, and there are PIs and co-PIs, and I'm given only 20 minutes. Unfortunately, I'm not able to put up the list of all, but I know that at least 5 or 6 of them, if not more, are already attending this call. And therefore, I salute you all for the great work that you have done, sometimes under very, very difficult situations. And if you just write about the incidents which happened during InDiab, that will make a book by itself. The number of times we got arrested in different places for things we didn't do, permissions being obtained in a slightly different name, and a fax from ICMR to get them out of jail, and so on and so forth, to arrows being shot in I think in Meghalaya at our staff, to getting kidnapped in one place. That is a whole story by itself. And that's a behind the scenes thing, which I think equally needs to be written about, which we will write in subsequent papers. But why this national study, you may ask? Because very often we have been asked, why are you doing this, almost impossible study, and is it really worth it? Now, this is before we actually did the study, Dr. Anjana wrote an article in ICMR actually making the case for doing a national study. And this is the justification. There was no national study on diabetes since ICMR study done in 1972. And that ICMR study was done in 6 cities of India and 6 villages, literally 6 villages about 50 or 100 kilometers away from that city. And they were only randomly chosen 6 cities. Many parts were not even represented, and literally 1 village next to that. And that's the only national kind of study on diabetes which was done. And no study on diabetes representative India had ever been done to look at the prevalence of diabetes. Between 1994 and 2008, 3 studies were done. The National Urban Diabetes Study, which focused only on the metros, the 6 metros, Delhi, Mumbai, Kolkata, Chennai, Bangalore, and Hyderabad. But it left out the smaller cities, it left out the towns, it left out the villages. And then there was another study called as a PODIS study, the Prevalence of Diabetes in India study, which left out all the metros. They picked a few small towns and villages. And again, these were not representative, didn't cover the whole city, but or the whole state or a whole the country, but just a few randomly selected convenient sampling. The WHO ICMR risk factor surveillance was a very good study. It took an industrial cohort and it was fairly representative, but the problem was it was only using questionnaire. No blood samples were drawn. So all we could get was known diabetes. And we know that 50% of people do not know that they have diabetes. No study, there is no study at all, which has studied all the states of India. And there is no national data on pre-diabetes. Whenever they study only diabetes, they just study pre-diabetes. So therefore, the strong regional focus of all the above studies makes them unsuitable to be used to represent the data or the health status of the whole nation. And as I speak, I would like to tell you that we have submitted a paper actually including all the 30 states data and the health status. And this is under review in one of the Lancet publications, one of the Lancet journals, and hopefully this should be published soon. And this will be the real national data from ICMR. Now, how did we do ICMR? Naturally, when a study of the whole country, this is almost 1/6 of the whole of humanity, you're talking about now 1.32 billion people out of the 7 billion in the world, it's not easy to do that. And therefore, the funding also came in phases. And so we had a phase 1 where Chandigarh, Jharkhand, Maharashtra, and Tamil Nadu was done. Phase 2 was then done with Andhra Pradesh, at that time not divided. So you can see how much history has happened since then. So we did undivided Andhra Pradesh. Later on, after finishing the study, Andhra got divided into Andhra and Telangana. Bihar, Gujarat, Karnataka, and Punjab were finished. And then we had the phase 3 where Delhi, Rajasthan, Madhya Pradesh, and UP were done. And then phase 4 where Chhattisgarh, Goa, Haryana, Kerala, and Puducherry was done. Phase 5 where Himachal, Uttarakhand, Odisha, West Bengal, and Jammu and Kashmir was done, but Jammu and Kashmir is still on hold. We'll won't go into that. And then, of course, the entire Northeast was done. Arunachal Pradesh, Assam, Manipur, Meghalaya, Mizoram, Nagaland, Sikkim, and Tripura. In fact, when we started the study 11 years ago, people said that it will be impossible to do Northeast. How will you go there? People won't allow you to take blood. In Nagaland, there is a saying that if a non-Naga draws the blood of a Naga, his head will be chopped off. So this is what the good news we were told before we went to Nagaland. So you can imagine how scared our people were when they went there. But nothing of the type happened with the support of ICMR and all the collaborating institutes that we had and the superb PIs that we had in every place. Everything. We did have some minor episodes here and there, but no serious things happened. And the study was actually completed. We have, as the DG announced, we have completed 30 states and union territories. It's actually 28 states and 2 union territories. And the sample size, as you already mentioned, is 1,13,043. In all humility, I would like to add that is the world's largest ever done epidemiological study on diabetes. The second largest was in China, where 53,000 was done. And China did not do the whole of China. They took a few spots here and there, a few samples. In the NHANE study done in the US, in the OSDIAB study done in Australia, in none of these studies ever done by any of these countries was a whole country study. they would take one in the east, one in the west, one in the north, or one in the south, or somewhere, and then take representative samples. But they did not do anywhere in the world, to my knowledge, a complete country with every state representative taking a representative sample. And in that sense, in fact, we've drawn the graphs of the INDIAB, and then we drew the census graph on top of it, and one sat exactly snugly on top of the other. So that shows the precision with which the sampling has been done. And of course, the quality control has been extensively gone in through that, because the ICMR had the field visits arranged for almost every state, and we had representatives of ICMR, representatives of the expert group, ICMR expert group, and we have Dr. Ashok Kumar Das here, we probably have Dr. Madhu here, Dr. P.V. Rao. All of them have visited virtually every state in India and made field visits while the study was going on to ensure the quality of the study. So let's briefly look at the results. I know I have a limited time, so it will be impossible for me to show you 30 state data. And remember, the study is not just diabetes. We have diabetes. We'll be happy to note, DG sir, that we have hypertension data also, dyslipidemia, obesity. And therefore, I try to give you a bird's eye view of the whole data rather than just focusing on 30 states on just one disease. Now, let's get into diabetes first, because that is the primary aim of the study. What is the overall weighted prevalence of diabetes in India? This weighting, of course, was done using statistical help. We had the Population Institute in Mumbai helping us. And if you look at the overall urban prevalence of diabetes in India today, after we have completed the 30 states, it's 13.3% of adults above 20 years of age who have diabetes in urban India. Now, rural India, when we started the study, was, or 10, 15 years ago, used to be 1%, 2%, 3%. Today, it's fast catching up, and it's almost 8%. And this includes some of the most, the poorest states in India. And even given that, the rural India is catching up, and in some states, like Kerala, the rural prevalence has actually exceeded the urban prevalence. Now, I'm just showing you the states with the lowest prevalence, the last three, as far as the lowest prevalence is concerned, and the highest prevalence is concerned. So the lowest prevalence, as far as the study is concerned, till date is UP with 4.2%, Bihar 4.3%, and Meghalaya 4.5%. Puducherry is in third place as the third highest with 20.3, Goa with 23.3, and Kerala with 23.5%. Now remember, this is not a state, this is not a city that we are talking about. Dr. Nikhil Tandon and I have published earlier that in Delhi city and in Chennai city, we got these kind of figures, 23% of the population, but that's only in a city. This is in the whole state, urban, rural, all put together. We are now seeing a quarter of people in these states having diabetes. This is a point which I want to tell you why we are so much bothered about diabetes in India. People used to think that diabetes is a disease of old age. Okay, when you become 70, 80 years old, you'll get a little diabetes. So why worry about it? Now, remember that the duration of the diabetes is the one which influences the risk of getting diabetes. So as the DG said, at age 50, if you are given a choice between diabetes and hypertension, I would also probably pick diabetes if God asked me, because the risk of strokes after 50, 60 years of age with hypertension is much more. But if God had asked me at the age of 20, which will you choose? I'll probably choose hypertension, because diabetes, by the time you live to 30, 40 years, almost 50% of them develop kidney disease. And you just imagine if 100 people had end-stage renal disease in India, only 2 to 3% of them can afford either dialysis or transplantation. And that's why this graph becomes very important. This is an old slide. This is not from INDIAB. Next slide will show you the INDIAB data. So what is shown here in red is the Asian Indian data from CARS, which Dr. Nikhil Tandon and I published. And you can see where the takeoff of the age is. By age 25, as he showed you also in the YDR already, the age type 2 diabetes taking off at 20 years, you can see how it is going. And none of the other ethnic groups, whether it's white, Hispanic, or black, come anywhere near the prevalence rates that we are seeing in Indians. But of course, this is based on 2 cities. So you may say, well, it may be because it's in the cities. So that's why INDIAB becomes very important, because it's based on the whole country. Now look at INDIAB. Just remember this figure here. If you just remember this 20-year thing here and where the takeoff occurs. Now let's look at INDIAB, and you can see INDIAB, what is shown here is urban in red and rural in green. And then you have the dotted line, which is females, and the continuous line, which is male. Irrespective, of course, the urban is higher than the rural. Men and women, not much different. But look at the takeoff of the diabetes. Whether it's urban, rural, males, or females, the same graph is seen. So it means that in India, 20 to 25 years is when the takeoff occurs. So imagine if you're just 50 years old, you already finished 25 years of diabetes. And in 25 years, you can already go blind. You could have had a bypass surgery done or a couple of stents put in. You could have lost your leg due to an amputation, due to neuropathy or peripheral vascular disease, or you may be in renal failure, looking for that donor or looking for dialysis and who's going to pay for that dialysis. So this is a very sad situation. And unfortunately, every decade when we study, we are seeing that it is shifting more and more to the left, and younger people are getting diabetes. And therefore, I don't think we should discount diabetes as adding to the dialysis, because I think it's equally important, especially when the youngsters get it. Now, going on to pre-diabetes. Now, why should we study pre-diabetes? It's because pre-diabetes tells you whether the epidemic is over or not. It's something like in COVID, if you all have zero positivity, you all developed antibodies, you know, okay, that many people have developed antibodies, so we need not worry about that. Pre-diabetes, if your pre-diabetes prevalence is low, we can say, well, it's all over. The diabetes epidemic is almost over. 10 years from now, you're not going to get it. Not only is the pre-diabetes very high, if you remember that rural figure, the urban pre-diabetes figure is 13. Pre-diabetes is 14, so it's still not over. But look at rural, where we had 7% there, it's 14% here. It's even more than the urban. So what does it mean? People in the rural areas are just waiting to convert to diabetes. And Dr. Dhaliwal put it very correctly when he said, even if 3%, 4% of India converts, you can imagine how many million people are going to get diabetes. And in rural areas, who's going to give the treatment to them? Do we have specialist centers? Do we have follow-up centers? Do we have people to look at the eyes? Do we have cameras to take pictures? And therefore, any increase in rural areas is very worrisome. And that is why prevention is of utmost importance. Now, let me give you the 3 states with the lowest pre-diabetes and the highest pre-diabetes. The lowest pre-diabetes was in Mizoram, and then Manipur, and then Jharkhand. But look at the highest pre-diabetes. West Bengal, 23%, Puducherry, 24%, Sikkim, 32%, 31.8%. So there's an explosion of diabetes just waiting to occur in Sikkim. When we first got these results in the advisory board, expert group, we didn't believe it. So we went back and checked it and checked it and checked it, and we found that yes, it's going to, just like Goa we saw and Kerala we saw, 10 years from now, you'll find so many people with diabetes in Sikkim that it will start affecting the very economy possibly, or at least the health systems will be overburdened. And that's what INDIAB is teaching us. Now let's move to obesity, generalized obesity as judged by the body mass index. And you can see that 37% of urban India and 22% of rural India is obese, using a BMI of 25 or more. And now if you look at the states with the lowest prevalence of generalized obesity, it's 11%, Jharkhand, the lowest, Meghalaya, 13%, and Bihar, 14.5. Look at the highest ones, almost unbelievable. 42% of Delhi is obese. Kerala, 44%. Puducherry, 46% of people, the entire Puducherry population of adults is obese. And this is generalized obesity. Now let's look at abdominal obesity. Abdominal obesity using waist circumference, more than 90 centimeters for males, more than 90 centimeters male, more than 80 centimeters in females. 48% of the urban population of the whole of India has abdominal obesity. 32% of the rural population, whom we thought were very lean and malnourished, are now having obesity. Let's look at the lowest three and the highest three in terms of abdominal obesity. It's again Jharkhand at the lowest, and then followed by Maharashtra and Andhra Pradesh. But look at the highest: Haryana, 57%, Punjab, 57%, and Kerala, 58%, having abdominal obesity. Moving on to hypertension, overall in urban areas, 35% have hypertension, and rural, 30% have hypertension. So no big urban-rural divide like we saw for diabetes. If you look at the states with the lowest hypertension prevalence, 23% Meghalaya, 23% Madhya Pradesh, 25% Mizoram. Look at Kerala, 42%, Punjab, 44%, and Sikkim, 44%. So Sikkim again having not only just the epidemic of diabetes, but also hypertension. Hypercholesterolemia, we have data on triglyceride, low HDL, and everything. I'm not showing you that. I'm just showing you hypercholesterolemia. A quarter of the people in urban areas have high cholesterol, and 1/5 of those in rural areas have high cholesterol. Which are the states which have the lowest cholesterol? Jharkhand, Assam, Arunachal Pradesh, and Meghalaya. Whereas the highest are in Himachal Pradesh, Goa, and Kerala. We have looked at it, and we'll probably be able to give you the data later. We believe that it's coconut oil in Goa and Kerala, which is adding to the high LDL levels, and whether it's really damaging them or producing, that's a different story. But we looked at the oils, and we'll be able to be writing up the oil paper also, and that should be also out quite soon. So what have we learned from the ICMR INDIAB study? What are the lessons that we have learned? The INDIAB study has shown that the burden of diabetes and pre-diabetes is very high in India, and if anything, the numbers are increasing. The prevalence of diabetes in India varies widely in different states, from 4% in Uttar Pradesh to 23.5% in Kerala. The prevalence of pre-diabetes in India varies from 6% in Mizoram to 31.8% in Sikkim. There is a higher prevalence of diabetes in urban areas compared to rural areas, but the rural areas are fast catching up. Maybe if you do a repeat of INDIAB in 10 years' time, we may see the rural areas actually exceeding the urban areas. Because in urban areas, people are conscious, they start exercising and so on, whereas in rural areas, that even the education awareness is much less. Prevalence of hypertension, obesity, and hypercholesterolemia are also high in all the regions studied. The prevalence of hypertension in India varies widely in different states, from 23% in Meghalaya to 44% in Sikkim. The prevalence of generalized obesity varies from 11% in Jharkhand to almost 46% in Puducherry. Unbelievable figures. The prevalence of abdominal obesity varies from almost 17% in Jharkhand to almost 60% in Kerala. Can you believe that? 60% of everybody in Kerala having abdominal obesity. Is it surprising then that their diabetes rates are so high? The prevalence of hypercholesterolemia in India also varies widely, from 4.9% in Jharkhand to almost 50% in Kerala. I'd like to thank you, and if there are any questions, I've been told that you can email them at Insulin Centenary Symposium at gmail.com, because there are two presentations, and maybe all of you have a lot of questions in the audience, and if you ask us the questions, we'll try to individually send you the answers. I would like to now stop here. Once again, thanking ICMR, DG, Dr. Balram Bhargav, Dr. Dhaliwal, Dr. Tanveer Kaur, and the expert committee, the ICMR INDIAB expert committee, for all the support over the last 11 to 12 years, and also all the PIs and co-PIs of all the 30 states who have been such a great source of support as we carried out this very difficult study in every nook and corner of the country. Thank you very much, and I'll stop here.
So coming to the last part of the symposium, I would like to thank my first and foremost thanks to Director General ICMR and Secretary Department of Health Research, Professor Balram Bhargav, for his encouragement, mentorship, and support in organizing this symposium. And purpose was to just mark 100 years of insulin discovery, and we wanted to celebrate it, and we took this opportunity that let us showcase our two major studies, which will help. And it is very pleasing to note that around 200 outside participants are participating outside ICMR and ICMR institutes. So I hope they will also learn from these two studies. And if there are any questions, as Dr. Mohan has said, we have created an email ID and we will try to respond to all of them. My special thanks to Dr. R.S. Dhaliwal, head NCD, for his constant motivation and guidance, and he has been a pillar of support in spearheading these studies. We are equally thankful to Professor Nikhil Tandon and Professor V. Mohan, whom you have just heard. Dr. Tandon for establishing a largest national registry of youth onset diabetes in the world. And of course, we had many challenges at administrative level, and Dr. Nikhil had at his institute level in coordinating with the centers, identifying the centers, getting the data. So I cannot finish in one statement. So it has been a journey of almost 15 years, which we have been going through, and some things we wanted to forget, something we wanted to remember. So, and Dr. V. Mohan for undertaking a large survey of diabetes, which was primarily focused on type 2 diabetes. And it was again very challenging task, which you have heard that there was risk to field teams, they were attacked, but the motivation was never gone down. So he has taken immense interest in training the field teams, and he has a very motivating team, which we have been seeing and interacting with them during our field visits. My heartfelt thanks to the members of the expert group, who they have been guiding us through thick and thin, and they were available on the phone call when we need any guidance from them. Both these programs have been very useful in providing the data sets and highlight the disease burden in our country. And I think I'm sure they provide the platform for policy planning and the allocation of resources. We keep on updating Ministry of Health also through one form or the other, through parliament questions, through the notes, and through the programs which they plan or they want to change. So I'm equally thankful to the administrative help which was offered by our online team. Dr. Lukesh Sharma is there, Mr. Raj is there. They have been very supportive. Last but not the least, the thanks to all the participants and the colleagues who have taken their time out in attending the symposium. And we are hopeful that they found it useful. Thank you.
Any last words from DG, sir?
I just want to congratulate everyone, and I want to congratulate the two speakers for excellent presentation. The more important point I would like to emphasize on it, that seeing the numbers of the prevalence in different states, I think we have to start some sort of a ICMR movement for control of diabetes, and that should be done on a war footing. In terms of the publications, if you feel we can have a special issue of the Indian Journal of Medical Research on INDIAB and YDR, just dedicated to that, with all the publications on that, the expert group can discuss that. And today's symposium will be present on the ICMR website. We'll have the entire lectures on the ICMR website. We had the BCG Centenary Symposium a month or two back, and we have the Insulin Centenary Symposium, and the talks will be available on the website for the same. So please think some big ideas, national ideas. We are happy to fund biggest ideas, and I would request the expert group to control diabetes epidemic in India by some bold and aggressive steps. So I wish all the best. Thank you so much.
Thank you, sir. Thank you so much. Any national anthem, or we just close, madam? Just close. Thank you. Thank you so much.
Thank you. Bye-bye, everybody.
Bye-bye. Bye-bye, Nikhil. Thank you.